All right, so this is take two of this slide. Unfortunately, my computer only has so much memory and it decided to stop recording the video at the slide, so we will continue. So we were talking about brain doesn't have energy reserves, so that's why it's so sensitive to decreases in blood flow and or oxygenation. So not only are there asphyxial injuries from lack of oxygen in the atmosphere or a lack of blood flow to the brain, but there can also be chemical asphyxiants. Some examples of those are carbon monoxide. Carbon monoxide is a common toxin that we'll see with fires. Um, is a characteristic cherry red blood. And the reason why that is because CO2 has a very strong affinity for hemoglobin, 250 times greater than that of O2 to be specific. So the carbon monoxide displaces the oxygen from the hemoglobin, but because the hemoglobin has something bound to it, it's still that red color that we associate with having a fully saturated hemoglobin. Cyanide is another type of chemical asphyxiant. It functions slightly differently. It binds to the iron on the hemoglobin molecule and prevents it from then binding to oxygen. Again, there's a characteristic cherry red appearance of the blood, and there's also a characteristic almond smell that some people who are genetically predisposed can smell, apparently. Did not know this. So, fun fact for y'all. Next is drowning. There's two types of drowning. There's dry lung drowning and wet lung drowning. Wet lung drowning's pretty obvious, so I won't go into further detail about that. But dry lung drownings has a slight implication when it comes to anesthesia. This is 15% of drownings are dry lung drowning. The reason why it's important to anesthesia providers is because the mechanism behind dry lung drowning is the fact that the water causes a reflex called a laryngospasm. And that laryngospasm is typically a protective reflex. Your vocal cords close in response to any type of foreign stimulation, and that prevents, theoretically, from stuff getting into the lungs. So, with a dry lung drowning, the laryngospasm prevents the water from getting into the lungs, which is good. However, the laryngospasm also prevents air from coming in to the lungs after the water is resolved. So while it can be a protective reflex, oftentimes it lasts in such a long time that it actually becomes detrimental. And we often see laryngospasms during emergence of anesthesia. So the laryngospasm is mediated by the vagus nerve. So that's very important for you to know, both for this class and also in the future when you're taking boards, when you're going through respiratory, when you're going through airway anatomy. This will come up over and over and over again. So you definitely want to have a really good grasp on this mechanism. So thermal injuries, obviously hypothermia is less than 35, greater than hyperthermia is greater than 37.5. The body is very sensitive to changes in temperature. All of the cellular functions within the body can be impacted by temperature. Um, how enzymes work can be affected by temperature. How drugs are metabolized can be affected by temperature, either too hot or too cold. So, on a basic level, that's how that functions. Blood doesn't coagulate the way it should. The immune system doesn't function the way it should. Things tend to function slower when they're hypothermic. The less energy less likely for the reactions to occur, and hyperthermia is the opposite. With hyperthermia, the biggest concern is with how the temperature affects the shape of proteins within the body, and thus affecting how those proteins function. So another type of thermal injury, while it's not specifically temperature related, it's slightly slightly related, so we'll talk about it here, but this is another big one that you'll have to know for boards. You'll have to commit all this stuff to memory. You'll see this further on in your anesthesia career, your educational career, so you have to learn this now. So malignant hyperthermia is basically a reaction to certain types of drugs that we use in anesthesia. It has a genetic component. People are genetically predisposed to having this type of reaction. Basically, the gene that encodes for the ranitidine receptor, it's called the RYR1 gene. That gene encodes for this receptor, and in some people that gene is faulty. You'll see large populations, I shouldn't say large populations, but it's more common in certain populations in Wisconsin. For some reason, I guess there's a small subset of people who have this gene and pass it around up there. There's a couple other areas where it's common, but it's a rare problem, but it's a big problem when it comes to anesthesia, so you have to know and understand how this mechanism works. Long story short, this ranitidine receptor plays a role in the regulation of calcium that enters a sarcoplasmic reticulum, which is the structural component of a muscle cell. So when the calcium enters, it causes a muscle contraction, and if you can't get rid of that calcium from inside the cell, or you can't regulate it properly, the muscle has a sustained contraction. And with that sustained contraction, you have an increase in temperature, increase in CO2 buildup because you're using more oxygen, because you need more oxygen to make more ATP, have all the byproducts of that ATP production, carbon dioxide. Get acidosis from that, cardiovascular dysfunction because of electrolyte imbalances because of the increased CO2 and increased temperature. So overall, basically you want to know that with malignant hyperthermia, you have a dysregulation of intracellular calcium within the sarcomere, within the muscle cell, and that leads to sustained muscle contraction. Neuroleptic malignant syndrome is another issue with drugs. It's a reaction to certain types of drugs. So while it's not an injury that's created from temperature itself, one of the side effects is increased temperature. So we'll talk about it here. Basically, it's caused by certain classes of antipsychotic drugs and dopaminergic drugs. A lot of antipsychotic drugs have a dopaminergic component or affect how dopamine functions within the body. So it's those drugs that cause this response. Basically, dopamine causes a bunch of different issues. It affects the autonomic function, it affects the hypothalamus, which is responsible for temperature regulation, and it also affects muscle contraction. So all three of those different components all function together to create the symptoms that you see. So common symptoms: muscle rigidity, autonomic dysregulation, hyperthermia. The hyperthermia is not only a result of the drug's effect on the hypothalamus, but it's also a reflection of the muscle rigidity. So when you have a sustained muscle contraction, body's using a lot of energy, it's using a lot of energy, and it's converting that energy into thermal energy, and that's why you get the hyperthermia. Similar mechanism that's involved with the malignant hyperthermia that we talked about one slide previous. You also get some extrapyramidal side effects. High altitude injuries. So I don't know if any of you have gone skiing, Colorado, Utah, wherever it's high, or gone hiking. but this is a common problem for people who function in those types of environments. Symptoms of high altitude injuries, going back one step, there's multiple different names for this type of injury. You'll hear acute mountain sickness. There's a bunch of other names and acronyms, but basically they're all synonymous with each other. Symptoms include nausea and vomiting, weakness, dizziness, headache, difficulty sleeping. So the mechanism by which this works, it's kind of interesting, is hypoxia has different effects on different types of vasculature. For the most part, throughout the body, when tissues are hypoxic, blood vessels have blood within them that have less oxygen, they respond by vasodilating. And by vasodilating, they theoretically increase the amount of blood flow to get more blood with that oxygen to the tissues that need it. So it's a compensatory mechanism that the body uses. It's like a failsafe. So while that's good in most cases, the pulmonary vasculature is very unique in that it responds the opposite to hypoxia. It actually causes vasoconstriction. And you'll learn more about this in Dr. Kapalin's class when you cover respiratory. But for our purposes, that's the basic mechanism behind high altitude injuries and why you see the symptoms that you see. The nausea and vomiting are related to the cerebral vasodilation. When you have cerebral vasodilation, that increase in blood flow causes an increase in pressure, which triggers the nausea and vomiting from cerebral swelling. And then that's why you get the weakness when your central nervous system swells, doesn't function the way it should. You get weakness from that, dizziness, headache, all that stuff. And then as far as the lung issues, as far as the pulmonary edema and things of that sort, that's a result of a pulmonary vasoconstriction. So very important to understand that throughout most of the body, response to hypoxia is vasodilation. Within the pulmonary vasculature, vasoconstriction. That's, again, another topic that's going to be very important as you progress through your anesthesia career. That's something you're going to see on boards, something you'll see in your future classes and clinicals, so might as well start learning it now. Ionizing radiation. So ionizing radiation is damage that's caused by positively charged atoms. Examples include X-rays, gamma rays, neutrons, protons. The most common sources that we see here are X-rays from medical imaging, and then also the rays that we get from the sun that make it through our atmosphere. We can easily see the damage that ionizing radiation causes when we go outside for the first time, which hopefully we'll all be able to do shortly here. You get a little bit of sun. Sometimes you get too much sun, you get a sunburn. All cells are affected by ionizing radiation. All cell cycles are affected by ionizing radiation, especially the G2 phase. Again, you'll learn more about the G2 phase in Dr. Gopalin's class. But basically why that is important is cells that are rapidly dividing are the ones that are most likely to be in the G2 phase at some point in their lifespan. And those are the ones that are most susceptible to ionizing radiation. So cells that are fast growing, for example, cancer cells that are fast growing, that's the reason why they use certain types of positively charged atoms to kill cancer cells, because they're more susceptible. And the inverse square law is the concept that we use as healthcare providers to protect us from this ionizing radiation. It's not so applicable of a concept in pathophysiology, but it'll be something, again, you'll see further on in your anesthesia career, so I might as well introduce it to you now. But long story short, the further away you are from the source of ionizing radiation, the less radiation it receives as a function of the inverse square of the distance. So injuries of accumulation. Your body metabolizes a lot of substances, it gets rid of a lot of substances. Sometimes your body can't get rid of these substances that it needs to. So there's several different examples. I'll talk about some of the most common ones here. Again, most of these are actually not very common at all, but you may encounter them in your career. More likely to encounter these on boards, so that's why we're going through them now. Glycogen storage disease, it's a very rare thing. There's really not a whole lot to say about it other than what's on these slides, so I'm not really going to labor the point here. So you can have an accumulation of proteins. Usually when you have an accumulation of proteins, your body could be making too many proteins because there's some type of stimulus that's telling your cells, hey, I need to make more DNA to make more proteins. Most likely when you have issues with protein accumulation, it's because these proteins are being misfolded. As you may or may not know, the function of a protein is exquisitely tied to its shape. There's primary, secondary, tertiary, quaternary structures of a protein, and it's those structures that are critical to its function. Any slight change into the shape of a protein can render it inactive. Some classic examples of this are alpha-1 antitrypsin protein. Some people have a disease what we call alpha-1 antitrypsin deficiency. It's an enzyme that's responsible for helping to shape a specific protein that is found all over the body, but primarily in the lungs. If this protein is misfolded, it can accumulate and it can cause emphysema in the lungs. It's a rare thing that happens, but it's something you'll always see on boards, so that's why we're talking about it here. And the treatment for that is, unfortunately, liver transplant. There's several neurodegenerative disorders that occur because of misfolded proteins: Alzheimer's, Parkinson's, Huntington's disease. They're all types of neurodegenerative disorders, and the mechanism involved is accumulation of proteins. Accumulation of pigments can be a problem in some people, particularly melanin. Melanin is derived from tyrosine, which is amino acid. Increased production of melanin can be seen in diseases such as Addison's disease. That's one of the characteristics of that disease, and it's related to ACTH release, which stimulates melanin production. And also melanomas are another example. Bilirubin. Accumulation of bilirubin is harmful to humans, particularly newborns. It's not necessarily that newborns are more susceptible to it, but they're more likely to have increased bilirubin levels because of their inability to metabolize it. So bilirubin is derived from porphyrin molecules, which is one of the types of molecules that makes up hemoglobin molecule. Increased levels of bilirubin can cause jaundice, leads to icterus. Levels beyond 1.5 to 2 milligrams per deciliter. So there's several different causes of increased bilirubin. So if you think about it, bilirubin is derived from the porphyrin molecules found in hemoglobin. Obviously, your body makes hemoglobin to make red blood cells. Hemoglobin can also get destroyed. And in the process, you have this red blood cells get destroyed. The hemoglobin within those red blood cells has to be processed. And if the process gets overwhelmed, then you can have an increase of bilirubin and the resulting symptoms from that. So understanding that, it can kind of already tell you what the causes are. You don't need to memorize the list. You can just kind of think about it in your own head how this process works, and you can understand the causes of increased bilirubin. So, increased red blood cell destruction from many different reasons, either from natural processes or from unnatural processes. Impaired metabolism or excretion of bilirubin. Bilirubin, like any other toxin or any other substance in the body, has to be processed in order to be excreted. In its natural form, unconjugated bilirubin is lipid soluble, so you can't eliminate it from your body easily. It needs to be changed into a water soluble form. Also, obstruction of the bile duct, which is where bile flows through once it's processed, can lead to increased bilirubin levels. So we talked about this briefly a few minutes ago. There's two types of bilirubin: conjugated, which is water soluble; unconjugated, which is lipid soluble. Again, this goes back to the CYP450 system. You have your phase 1 reactions, and you have your phase 2 reactions to make things more water soluble so you can excrete them. So, while that's not quite the mechanism that's going on here, the same concept applies. You basically got to take this bilirubin, conjugate it, make it water soluble so your body can excrete it. So the reason why unconjugated bilirubin, or an increase in unconjugated bilirubin levels, causes problems is because it can enter a plasma membrane because it is lipid soluble, and it uncouples the oxidative phosphorylation, which is a process that occurs inside the mitochondria that makes energy. So the bilirubin affects the mitochondria. Mitochondria can't make ATP. Lack of ATP leads to all the things that we have been talking about these last hour and a half. Increase in levels of certain electrolytes can cause issues. Calcium, urate, increased uric acid levels lead to gout. There's really not a whole lot to say about that. We were talking about calcium earlier when we were talking about like atrophy, necrosis, things of that sort. There was a table, it's like 2.1 of your textbook, where it shows all the steps of a cell from adaptation to injury to death, and like the last stage was calcium infiltration. Calcium infiltration is usually one of the last signs of cell death. That's one of the last processes that happen, and within the body you can see that often. You can see it in the heart. It's a common process in the heart. You can see it in the aorta. Actually, when you do your heart rotation and you do CABGs, they'll actually scan the aorta with an ultrasound machine. That's one of the steps they do before they start surgery, and the reason why they do that is to look for calcifications within the aorta for when they cannulate. So again, that just goes to show, it seems like a lot of this stuff isn't necessary, or like, why am I learning this? But it all will relate down the road as you go through your anesthesia education career. So manifestations of cellular injury. There's many overt signs that cells are being injured. You have fever, increased heart rate, increased number of leukocytes, pain. Those are all fairly obvious, and there's multiple different mechanisms that are responsible for those signs and symptoms. One of the most important things, or one of the most important manifestations, are the presence of intracellular enzymes and extracellular fluid. So obviously, intracellular enzymes are inside the cell. There's a membrane around each cell that keeps those enzymes where they belong, because if they were to get outside the cell, they could wreak havoc. So if a cell is injured to the point where the membrane's ruptured, this you can't take a microscope and look at every single cell in the body and say, oh, is this membrane damaged? Is this membrane not damaged? But you can look for the presence of enzymes. If you see those enzymes where they're not supposed to be, then you know that cell membranes ruptured, the cell's been significantly injured. And you can read the list here. It's pretty self-explanatory, but that's basically the concept that underlies why we look for troponins with heart attacks, why we look for amylase with pancreatitis, so on and so forth. So cell death. Obviously, this is the last step in that continuum of cell health. It's what we try to avoid. Sometimes it's avoidable, sometimes it's not. But there's two main types of cell death. There's necrosis and apoptosis. And the difference between the two is that apoptosis is an organized process. It's a process that the cell has innately within itself to, in an organized, clean way, deal with cell death. Sometimes cells need to die. They've served their purpose. They're no longer needed. Your body can make new cells to replace it. It's just something that needs to happen. So you want to have a nice, clean, organized way to handle the cell, all the stuff within the cell. You want to find a nice, clean way to get rid of it without affecting the rest of the body. On the other hand, sometimes the damage is so severe and so acute that the body doesn't have an organized way to handle it, and that's when you have necrosis. And that is by far the worst of the two. So this is a nice table that kind of summarizes the differences between necrosis and apoptosis. So I'll let you read that for yourselves, but I would focus on these differences because it's key, very important material. Here's a diagram that kind of talks about oxidative stress. We've already talked about this stuff, but this, I think, is a nice summary of how oxidative stress works. You see that red circle in the middle, the reactive oxygen species. You can see there's some little black lines that are going toward the mitochondria. It affects how the mitochondria functions, affects ATP production, energy levels, and overall function of the cell, which relies on the ATP. Those reactive oxygen species can also affect the DNA, can affect how it is turned on, how it's turned off, and then that, in effect, excuse me, affects the protein production, and the protein production is what determines how the cell functions. And when you impair both of those things, it leads to pathology, which can be seen in that orange oval there: aging, diabetes, autoimmune, neurological disorders. Everything in some way can be related to oxidative stress. So we try to prevent that as much as we can. So getting back to cell death, apoptosis, there's two types. There's an active cellular destruction, programmed cell death type 1. I'll let you read through all these little points here, but the main ones to consider is that this process is much like a garbage man. It's an intracellular process. Basically, it's taking all the harmful substances within the cell, all the trash, all the debris, all the stuff that's not needed anymore, metabolites, things of that sort. It gets them out of the cell. And that's good because it helps maintain normal cell function in a way that's anti-aging. Aging is an accumulation of things within the cell that are no longer needed, or at least that's one of the mechanisms for aging. So if you get rid of that stuff, then you don't have aging. It's normal or it's pathologic. It can be seen with neurodegenerative diseases, ischemic injuries, viral infections. So again, it's one of those things that's neither good nor bad, it's both. So autophagy is programmed cell death type 2. Cytoplasmic vesicles engulf organelles within the cell and get rid of them. And this, again, sometimes it's good, sometimes it's bad, but it's been implicated in the maintenance of cardiomyocytes, endothelial cells, vascular smooth muscle cells. So it can serve a valuable purpose in maintaining an organ, but sometimes if it gets out of control, it can cause issues. Porphyrias. We talked earlier about how those molecules make up hemoglobin, and hemoglobin makes up red blood cells. Hemoglobin, or heme molecule, is also important in that CYP450 enzyme that we talked about with metabolism and toxins. So heme isn't just for red blood cells, it actually functions in multiple different areas throughout the body. And that's critical to understand when it comes to porphyrias, because anything that can trigger the increased production of porphyrins I'm trying to think of the best way to say this. Any mechanism that stimulates either the CYP450 system or the increased production of red blood cells can trigger porphyrias, as we'll see in a little bit here. So the production of heme is regulated by aminolevulonic acid, otherwise known as ALA synthase. That's actually the more common name that you'll see in your anesthesia textbooks when we're talking about this disease. So a lack of this enzyme causes the formation and accumulation of intermediates. Any structure within the body has multiple steps for it to be made. And oftentimes, if there's a pathology involved with the making of those substances or enzymes or whatever they are, it's usually in one of those intermediate steps. There's a rate-limiting step or rate-limiting enzyme that prevents the proper construction of whatever we're talking about. And in this case, it's the heme molecule. So not enough ALA synthase, can't make proper heme molecules, and they accumulate, and that accumulation causes problems. So when we talk about things that trigger this disease, you got to look back at what stimulates the production of heme. You know, things that increase the production of red blood cells, lack of oxygen, stress, increase oxygen usage. Those things all increase red blood cell production and thus stimulate heme production. But if you don't have enough ALA synthase, then those heme molecules that you're trying to make those red blood cells, they're not proper, they're not functional, and then you get a buildup of them. Another thing that can stimulate heme production is certain drugs. Certain drugs are known to stimulate the CYP450 mechanism. And obviously heme is needed for that enzyme, so increase in drugs, increase in stimulation of the CYP450 system, increase production of heme, not enough ALA synthase, you have an accumulation of intermediates that causes you issues. So there's multiple different types or classifications of this disease. The only one that's really applicable to us is the acute one, and that's the one that's stimulated by drugs, essentially. It's autosomal dominant inheritance, occurs more frequently in women, third or fourth decade of life. There's multiple triggers, and again, you look at all these triggers, you can trace it back to increased red blood cell production or increased CYP450 activity. Signs and symptoms: severe abdominal pain. And abdominal pain is from the autonomic neuropathy. You'll learn later on when you cover GI that the GI system is very strongly innervated by the autonomic nervous system, and also it actually has its own nervous system called the enteric nervous system. So there's actually 3 nervous systems that you'll learn about. But that's why you get the abdominal pain. Autonomic nervous system instability, electrolyte disturbances related to the GI issues, neuropsychiatric disturbances. That's a very common symptom. So if you ever get a board question about signs and symptoms of someone who got a drug that triggers this disease, if you see neuropsychiatric disturbances, that's the one you want to pick. So you can see most of these symptoms are related to the neurological system. So there's multiple triggering drugs. It's only the acute form that's triggered by these drugs, but these are all drugs that are known to strongly increase the function of the CYP450 system. There's a lot of variability within people whether these drugs trigger this symptom or this disease. There's not a lot of consensus as far as which drugs cause this disease. And then also a lot of the testing was done in like not very limited scope, meaning that they were tested on rats or they were tested in a test tube and not really tested within a person. This, not a disease that you can test in someone or test the effects of a drug on someone, or that you would want to for ethical reasons. So there's a huge list, which I'll show you in the next slide, of drugs that are thought to cause this disease. Long story short, if you ever have someone with this disease, you'll probably have to look this stuff up. And one of the important concepts that you'll learn throughout this program is you got to use the resources that are available to you. For any type of major disease or rare disease, there is usually a foundation that's been developed because someone's had this disease and had some money and wanted to increase awareness or whatever. So those are some of the best places you can go to find information. If you're encountering a patient that has a rare disease you've never heard of, you got to know your resources, and that's one of the best resources you can use. And I think it's important for you guys to start developing the skills to utilize the resources available to you to find information quickly, whether it's for class, whether it's for clinicals, whether it's for your practice. So start learning how to find information that you don't have. If I'm teaching something in this class and it's not something you understand, you can obviously ask me to help clarify, but also, start looking on the internet, find some good, reliable resources that are peer-reviewed, that are reliable, that have good information. I'll start sharing some of mine that I have, but I like to hear from you guys when we actually talk in person, some of the resources you guys use to find out information about diseases you may not encountered, at least within your nursing background. So here's that chart that I promised you about all the drugs that can trigger porphyrias. Source of purine metabolism. This is what triggers gout. Purines are organic compounds found in meat and fish. They're metabolized in uric acid. Buildup of uric acid leads to hyperuricemia. So everyone's probably learned in nursing school the list of things that have purines in them. Cheeses, I think, are on there. Meats, fish, things of that sort. 50% occurs first in the base of the great toe. Can also cause some issues in the myocardium, which I thought was interesting and never really was taught that before. Basically, these crystals can collect in different areas of the body, not just the toe, but in all different types of tissues, and can lead to various issues. Risk factors for appearing metabolism. You guys can read all these yourself. Some of them are kind of self-explanatory. Some may not know, but you guys will now because you have this chart. So last disorder I'm going to talk about here is glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency is probably what you've more commonly heard this by. It's a deficiency in an enzyme that humans use to generate glutathione, and glutathione has a role in protecting against oxidative stress, which we've all talked about ad nauseum so far. It's actually more common than I thought. 400 million people worldwide have it. High prevalence in people of African descent, Asian descent, Mediterranean descent. X-linked recessive disorder. So if you hear X-linked disorder, who's most likely to get it? Men are, because we only have one X chromosome. We don't have a second properly functioning X chromosome or a gene on that second X chromosome to counteract or supplement the dysfunctional gene on the bad X chromosome. So men are more likely to get this, and the reason why it is in existence is because it protects against, or has a partial protection against, malaria. So like many diseases, sickle cell, I'm sure there's a couple other ones. Seems odd that a disease that causes dysfunction is spread through our genome. You would think that natural selection would have weeded that out, but in this particular case, there is a reason why it's in people's genetics, and because it protects against malaria. So things that increase oxidative stress trigger symptoms in people with G6PD deficiency. Things like infections, certain medications, fava-beans apparently causes issues. And we all know why oxidative stress is bad. So there is a list here of triggers. It's a long list. Some are high risk levels, some are low. Probably the most common medication that you would have to worry about is, at least that I've always been taught, is Tylenol. You don't want to give people like this Tylenol. I know you also don't want to give people like this B vitamins. I believe B vitamins can trigger issues with these patients as well. And actually, if they're going to be getting high dose B vitamin therapy intravenously, you actually should test people for G6PD prior to giving them those treatments. I actually was looking into starting a business doing IV therapy services, and I took a class, and that's where I learned that fun fact. And that oxidative stress, getting back to this disease, that oxidative stress actually causes hemolysis in the red blood cells, and that's the main mechanism by how this disease injures people. So those are the references. Sorry this was so boring, just listening to me talk the whole time. I really wish I could have been giving this talk in person, so that way we could have questions and exchange stories and things of that sort to make this more interesting. But it is what it is, and we'll get through it. If you have any questions, feel free to email me. I would suggest, as you're going through this material, write down all the questions that you have. Try to look up the questions yourself to try to find the information to practice those skills. Talk to your classmates, ask them if they have any questions, or if they have a better understanding of a particular topic. If not, bring those questions to our in-class discussions on Mondays and Thursdays, and we will get it figured out for you. Thank you very much.